radiation therapy. We're joined this morning by radiation oncologist Dr. Todd Scarbrough. And Dr. Scarbrough, got a special guest this morning. Who you got?
We do, and good morning.
Good morning.
This is Kevin Baker. Kevin is our chief radiation therapist at Anniston, and I've worked with Kevin for a couple of years, and as you know, I've been coming on the show now for several weeks, and I thought people are probably getting bored with just me coming on here, and I need someone who's better looking than me and smarter than me to come on.
Well, he's an Alabama guy, that's for sure.
And he's a native Alabamian, so now we have that covered, but yeah, we're glad to have Kevin here this morning.
Glad to be here this morning.
Right. Now, exactly what does Kevin do?
Kevin, why don't you tell us what you do?
I am the chief radiation therapist over the cancer centers with Alabama Cancer Care, and I basically help oversee all the therapists that we have employed with us. What a radiation therapist does more specifically is we carry out the prescription that the doctor writes. Dr. Scarbrough here will say we're looking at treating a prostate patient. He will decide the dose, how many fractions the patient's going to be getting, and from there we just we carry out the prescription as far as the therapist. We'll set the patient up. It's very hands-on. That's the part I really love about my job as being a radiation therapist, because every day we get to see the patient. We talk with the patient. We learn about their family, their friends, what's going on with their life. It's a very rewarding specialty that I'm in.
It's almost like you become part of their family.
We do. It's as far as therapists wise, not just me, but my colleagues and people I've worked with over the years, it's that's one of the most rewarding things. Is not like the interaction that, say, a nurse would have on the hospital floor, that you might see a patient for a day or so, or, just one day. I mean, we spend weeks with the patient, 10, 15 minutes a day, and we really do become family with them. One of the things that I've always said as a therapist, and I've always strived to do in my career, is, no matter what's going on with my life, when I walk in that back door, I leave it at the back door, because my worst day doesn't compare to some of my cancer patients' best days. So I leave everything there, and I'll pick it up on my way out. But as far as this therapy, it's one of the most rewarding fields that I've ever been a part of. As far as
Dr. Todd Scarbrough, who's a radiation oncologist, who's been with us for several weeks on Cancer Corner. The video was very, very informative about the radiotherapy.
Yeah, as you said, the fellow narrating the video didn't sound like he was from Alabama or Tennessee, but I thought it was a great instructional video. Obviously it was from England, just showing some of the ins and outs of radiation therapy. Like they mentioned there at the end, some of the myths about radiation therapy. We covered some of the myths about cancer before, but we didn't necessarily get into the myths of radiation therapy. And that is the main thing. I think, when people come to me and they've got first of all, you get a diagnosis of cancer, and in general, you don't know anything about cancer. And then on top of that, then they start talking about things like the surgery and the chemotherapy and the radiation therapy. And really, people don't know a lot about chemotherapy and radiation therapy. And with all due respect, people think they do know a lot about chemotherapy and radiation therapy. But I guess the main thing I would say about that is they may have a pretty good idea of chemotherapy and radiation therapy as it was 30, 40, 50 years ago. But today it's a completely different story. And depending on your cancer and depending on what part of your body, the discussion about the chemotherapy or the treatment in general or the radiation therapy will be a very different discussion from person to person. So somebody will come in and say, Aunt Minnie had this side effect with her breast cancer, and now I have a colon cancer, so I guess I'll get just the exact same side effects that she had. No, not really, because you've got a colon cancer and the other person had a breast cancer. So, that's what. And the therapists are great about that too, because, someone comes in and I'll spend an hour with them, but then they'll have other questions that come out later, and they see the therapists actually more than the doctor, because as Kevin was saying, he'll see him every day, 5 days a week. And during the treatment, in general, I may see him more often than this. I'll just see him 1 day a week for a few minutes, 1 day a week, just to make sure they're doing okay. So the therapists are really kind of where the rubber hits the road with these patients. And a great therapist makes a great radiation oncologist. That's why I love Kevin so much.
Good to have good folks on your team, isn't it? A question that never grows old, and you've talked about this before, but people can get confused about radiation therapy and chemotherapy.
Hey, Ken, do you find that they'll be confused about? I do.
We get that quite often, and then of course you, as far as they get confused about that, side effects, and then the horror stories of, like Dr. Scarbrough was saying, in the past treatments, maybe 40s and 50s, how the radiation was, or how even 20 or 30 years ago, how much our field is involved. You'll hear people talk about the side effects back then with Aunt Minnie or whatever, but today it's completely different ball game with the imaging techniques, the different therapy techniques we have now. It's just with the technology, it's advanced so much that the side effects are minimum these days, especially with radiation therapy.
Let's talk about some of those questions that people might have about radiation therapy, and we talked about some of the side effects, some of the myths of it, but walk us through a little bit about how a patient A might come into your services and requiring radiation therapy.
So they will almost always have their diagnosis of cancer made before they come in to see the radiation oncologist. And given that, so they'll come in, they'll know, for example, let's just take breast cancer for an example. So they'll obviously know that they have breast cancer, and another doctor has told them they need radiation therapy for their cancer. So they'll come and see me, and I'll begin the discussion process about that. Of course, that initial patient interview, ask them, if they ever had radiation therapy, get those sort of things out of the way. Then they generally decide that they're going to go ahead and take the radiation therapy. And then at that point, maybe on that very same day that I see them, I'll go to Kevin and I'll say, Kevin, we're going to plan this patient for radiation therapy. And the planning for radiation therapy will 99 times out of 100 be actually a CT scan that we do in our clinic. We have a CT scanner in our clinic. And people think of a CT scan in one way, to sort of like we're looking for something or we're going to do a scan for something. Actually, the CT scanner for a radiation oncologist just serves for us to make a three-dimensional model of a patient that we can put inside a computer to start the planning process. So the patient at that point will meet Kevin, and then Kevin, you will kind of like have some discussion with them. You may want to jump in and say what you will tell them on that.
From there,
let me ask quick, are the CT scans available at all the clinics?
We have a CT scanner at every clinic, don't we?
Yeah, okay.
Yeah.
All right, go ahead.
Yeah, so what happens is so we come in after he says, pretty much talks to the patient, they decide, yes, we're going to do radiation therapy. So the therapist takes over from there, and we'll bring the patient back to the room, and depending on what it is, let's say we're finishing up with a breast patient here, we'll explain to them that what I'm actually going to be doing today is I'm going to be setting the patient up in the treatment position they're going to be in. For a breast patient, most of the time it's both arms above head like this, so we can come at the different angles to treat the breast the way we need to. We explain to them about how we're going to be setting them up, making a mold for them. The mold is what we call a vac lock. It just kind of helps get the patient's arms in a certain position throughout the course of treatment. That's one of the keys to radiation therapy, is reproducibility. So we want to be able to get that patient in the exact same position every day of their treatment. We discuss with them how, exactly what we're doing that day. For instance, we'll have the patient lay down on the table. We'll lay them on a mold that we custom make to each patient to basically form their arms, to help hold their arms up throughout the course of treatment. Once we have them in that position, we just got to get them very straight, get them as straight and in line as we can, and then we put some marks on them. The marks are sort of like I always kid with the patients. I always try to put it in a term where they can, since I'm like sink our battleship. I just kind of put some marks on the patient that I see about in the area that we'll be treating. Dr. Scarbrough, once he takes that information, puts in a computer, he tells us exactly where we're going to be treating that with the computer. And so, the first day I explain to them that we do the CT scan, the planning takes effect. Dr. Scarbrough will do his part, dosimetry, physicists. There's just a huge team involved with the treatment planning. And then on the very first day, we come in, we line them up. We'll lay them on the table in their mold. We'll get them and set up to the marks they have on them, and we'll line them up just to those marks. And then we take what we call X-rays, or we'll do a CBCT, a verification sim, just being sure that we have them in the exact treatment position to what the doctor has asked for and where we're going to be treating, that everything lines up, matches perfectly. And once we do that, we start the treatments.
How soon, once you guys get together about the patient and then you're introducing them to Kevin, how soon does that process start as far as the first treatment is concerned?
It varies. If we don't have a particular need to rush it through, usually in about 5 business days. So they may come and see me on a Monday, and then they may be starting that radiation therapy the next Monday. If we wanted to, with the technology that we have nowadays, I could see them that morning and start the radiation that afternoon, if we wanted to, because we're actually transitioning right now to a technology where a lot of the beam shaping can be done on the fly, real time, inside the machine. It's got actually motors inside there and leaves. We call them leaves. They're not like leaves on a tree, but leaves that will shape that beam. Whereas in the past, we would actually have to make the plan. We would send it off to a company, and they would machine, like in a big machine shop like brass molds that would shape that beam. But as I said, now we actually have the technology where you can shape that real time. It's not especially new or fancy technology. Most centers have that, and now fortunately, we're going to have that as well. I want to add a few things. When he talks about marks on the skin, those are just magic marker marks that we put on their skin. And then, as I was thinking too, I sort of overlooked the fact that when the patient comes to see me, one of the things I do talk about are the potential side effects of radiation therapy. So if you talk about a breast cancer patient, the thing I tell a breast cancer patient is they're going to get some skin redness. And I say, this may be your sort of first interaction with medical radiation therapy, but almost everyone that I know of has had radiation before, in the form of when they go outside and the sunlight hits your skin, that's radiation that's hitting your skin. And then I ask the patient, so what happens in that situation? Then your skin gets red and irritated. And it's going to be the same thing, even though it's a completely different process at a molecular level. It's going to be the same thing when you come to see us, except instead of that few hours outside, it's going to be over several weeks of radiation therapy before you get that redness. Most breast cancer patients, I will say most breast cancer patients get about 3 weeks of treatment, Monday through Friday. It just takes a few minutes each day. They drive themselves in for every treatment, drive themselves back home. You don't get sick from that radiation therapy, as the video was talking about. You don't lose your hair. The radiation therapy is just an X-ray, and it's just aimed at the breast. So in reality, that's really the only place that you can get a side effect from radiation therapy, is where it's aimed and where it goes into your body. It really can't, and there's caveats to that, but it really can't cause a side effect outside that area. So if we aim it properly, that's the only place you're going to have a side effect.
We're talking with Dr. Todd Scarbrough, radiation oncologist, and also Kevin Baker, chief radiation therapist for the Alabama Cancer Care. And I guess, Kevin, when people get to you and you begin the process of getting them ready for the radiation treatment, radiation therapy, do you have to, a lot of times, people who come in and they're kind of fidgety, and they're kind of nervous and they've never been through this before. You kind of have to keep it light just a little bit sometimes?
Oh, we cut up and we joke with them, and we make it very light. I mean, it's like Dr. Scarbrough said, the side effects, we explain to them again the side effects, because we've all had that doctor block. I even had it. We go to sit in the doctor, he sits there and tells us what's going on with us, and we get out there and we think of a million questions I should have asked, or
and what did he say?
And what did he say? And so as a therapist, we're just constantly reassuring, relaying the information, and we do keep it very light. It's because it's a tough time that the patient's going through, obviously, because we all have stressful things going on in our life, but then they have a cancer diagnosis on top of that. So you can imagine what's going on in their life. So yeah, we cut up with them. We have a good time. So it's just, we just really try to make the mood relaxed. And we explain to them, listen, most cases it takes longer to drive yourself to the center than it does to get a treatment.
Oh, wow.
Yeah.
It literally 10 to 15 minutes treatment wise, and then you're driving back home. Yeah. And you know, and with us, we strive as therapists too to always stay on time, and we do, you know, 95% of the time really maintain time. If your time is 8:30, you'll be laying on the table receiving treatment by 8:30.
And receiving a treatment is the most boring, anticlimactic thing that will ever happen to you, because from your standpoint, you just come in, you lay down on a table, nothing touches you, you don't feel anything, you hear some noise from a machine that's actually quite a ways distant from your body. Then a few minutes later, somebody walks in the room and says, okay, you're done, see ya, and you get up and you go about your business. In the meantime, we've played your favorite music and the speakers inside the room, and there's artwork on the ceiling, you know, that you look at. I just saw a video, it was a cute video of a kid getting cancer. This was actually in England too, and they had a system rigged up with an iPad sort of hanging off the table so they could watch their Finding Nemo or whatever movie, you know, while they're getting the radiation therapy to sort of take their mind off of it. But again, it's a totally it's not even painful. You can't even feel it.
Wow. Does it tire the patient out? Is that something that they talk to you about, or is it just coming in, laying down a little while, and then leaving?
It's, you know, it's funny because going back to what Dr. Scarbrough said, it's boring to the patient. Literally, I mean, I've had patients get off the table, that's it? I mean, it's like, yes, sir, that's it. You're finished. Or yes, ma'am, that's it. That's you know, the fear of the unknown's worse than actually what it is, because it's so quick. They don't feel anything. I mean, we can kid with them sometimes. You know, I can whoop you with a stick, make you feel like you've had something if you want or something. But you know, all joking aside, it's a very easy process. The fear of the unknown's the worst with that, as far as the actual treatments itself.
I just saw a study, and this again was on breast cancer patients, where they interviewed about 1,000 breast cancer patients who had gotten radiation therapy, and 2% of the patients thought that the treatment process was like what they thought it was going to be like. 98% thought it was not like what they were going to be like, and the vast majority of that 98% thought that it was better than what they had feared.
Funny how our minds work, isn't it?
Yeah, but it was an amazing percentage from that standpoint. Yeah, so that's, you know, and you can tell people this before they come in, and I think sometimes they really don't believe you. And then on the last day of treatment, they're like, you know, they're like old pros at that point. And they're like, okay, we're done. It's that,
the effectiveness of it.
Yeah, and to go back to your initial question about the fatigue, I think the most fatiguing thing of the treatments is coming every day. Knowing that, hey, at 8:20 or 8:30, I have an appointment with cancer treatment. That's, you know, while I'm saying I got my cancer treatment at 8:30. I think that's the most fatiguing thing, is having every day, because a lot of our patients, older patients, retired, no longer have that every day. They have a time they have to be somewhere. And I think that is fatiguing, just coming back and forth. And two, a lot of times when the patient sees us, we're kind of the last stop. They've already had the original diagnosis, they've already had the surgery, they've possibly had chemo or not, and we're like the last step of the puzzle, the last piece of the puzzle.
A lot of the breast cancer patients that will see me, they will talk to other patients who've had breast cancer and radiation therapy, and they'll say, well, you know, I've heard that it makes you tired. And it is a common complaint, but like Kevin was just saying, you know, a lot of these patients, let's say they've already had about 3 or 4 months of chemotherapy, and then they'll start their radiation therapy, and then they'll be complaining after about a week and say, oh, I'm tired from the radiation therapy. I'll be like, well, yeah, you just came through, you know, some chemotherapy, but yeah, it might be the radiation therapy. And in all seriousness, I mean, the radiation therapy can have an effect on your body, but it depends. I mean, there's some people that come in and get radiation therapy one session for 15 minutes. So obviously, you really can't, if you're fatigued, you know, 2 or 3 months later, that's not from the radiation therapy. Now, someone who comes in, you know, some of our prostate patients will get 9 weeks of radiation therapy, 45 treatments. But a lot of them, as I've said before, even on the last day of treatment, will be out on the tennis court or the golf course that day. But we're treating such a small area of the body, even though it's 9 weeks, you probably can't get fatigued with that. Now with a breast, you know, the actual area that we're treating with a breast cancer can be very large. And even though it may be only 3 weeks or 6 weeks, I think there is something sometimes to the fatigue. Now it's not like, I can't even move, but they will complain that they're a little slower for sure.
Let's get to the effectiveness of the treatment.
You know, like the video was saying, probably about 17 to 20% of all outright cancer cures can be attributed just to radiation therapy. So radiation therapy is the most effective anti-cancer therapy for many types of cancers. I tease the medical oncologists, they're the ones who give drugs and chemotherapy, that the best chemotherapy agent for lymphoma, for example, is radiation therapy, even though it's not chemotherapy. But yeah, I mean, it is the way that radiation therapy works is to basically damage the DNA inside of a cancer cell so that it can't divide. And there's no cell that can resist that effect of radiation therapy if you give enough radiation therapy. The problem is that in a patient that has cancer, you know, there's a very tiny proportion of cells in their body that are actual cancer cells. And the normal cells have to see that radiation therapy too. And so that's the trade-off for a radiation oncologist. We've got normal cells sort of in the way of the cancer cells, and you need to attack the cancer cells as precisely as possible. But if you do that, radiation therapy promises a lot of cures for patients. And we give it differently nowadays than we gave it 10, 20, 30 years ago, in that we give really big doses of radiation therapy now per day, whereas we didn't do that before. Now, how can we do that? Because the technology is so good. We can aim that radiation therapy so well. We can do things that we call stereotactic, which is a big fancy word that to me just means a big dose of radiation given for one treatment. So, and in those patients, you know, the lung cancer patients, for example, can come in with an early stage lung cancer, and we give them 4 days of radiation therapy, and they can have an 80 to 90% cure rate from the radiation therapy.
Fantastic.
No surgery, no recovery period. They certainly don't get sick. They certainly don't lose their hair. You know, whereas the alternative is you go in the hospital and a thoracic surgeon cuts you open from here to here, spreads your ribs open, and removes part of your lung.
And that's quite a long recovery too, you know.
Yeah.
I mean, it's a big whack, so to speak, you know, and you feel it. And there's about a 1 in 200 chance that you'll die, you know, from that surgery. And there's no one, I won't say no one, but essentially no one who's ever died from radiation therapy given to a small area of their lung.
Final couple of moments this morning with Dr. Todd Scarbrough, a radiation oncologist, and Kevin Baker, the chief radiation therapist in the Anniston office. And Kevin, you go to all the centers, is that correct?
Yes, sir. We have, as our kit is a west side and an east side. We cover, you know, the west side is Winfield, Jasper, Tuscaloosa, and Demopolis, and the east side is Fort Payne, Anniston, Sylacauga, and Montgomery.
Yeah.
So we have the state covered. And that's a great thing for a lot of our local communities, because one of the other misconceptions about radiation therapy is people hear radiation therapy or cancer treatments, and their first instincts, I need to go to a major city and have this treatment done. And that's not the case for approximately probably 95% of the patients. You can have everything done locally in town.
And there's something to be said about, Dr. Scarbrough, having this treatment done in your hometown. You know, you feel more at ease, you feel more comfortable, you're going back to your own house in a little while.
Well, let's put this
in all seriousness, I think the cancer treatment is apt to work better if you are more comfortable with the treatment.
Well, put in perspective here, let's say, for instance, I live in Oxford and I'm going to drive to Birmingham for treatment. I'm going to drive an hour on the interstate.
Taking your life in your own hands.
Sit and wait for my treatment 10, 15, 30 minutes, depending on how time, get a 10-minute treatment, and then drive back another hour.
Wow.
When you could literally drive 10 to 15 minutes to one of the local centers there in your town. have the treatment in 10, 15 minutes and be home in 10, 15 minutes.
Half a day compared to an hour.
Yeah, now that would be fatiguing to me, is driving an hour for a 10-minute process every day for 9 weeks.
Absolutely.
So,
yeah, and these large cancer centers, they're fantastic. They're good.
Sure.
They're wonderful. But I thoroughly believe in my heart of hearts that everyone should have local access to world-class care. And that's what we try to do.
Fantastic. We talked about the video, and you touched on it briefly. Probably we've got 3 or 4 minutes left. Talk about the couple of other myths that we haven't touched on this morning that people are concerned about.
I noticed the video had hair loss. You know, a lot of times patients coming in, we're going to be treating their prostate or the breast, and they're assuming they're going to lose the hair on their head. That's a myth. Again, radiation is very, radiation is very precise. So if we're treating the breast, the only side effects you'll potentially see in that area is with that area of the breast. But in most cases, a reddening of the skin, like Dr. Scarbrough said, almost like a sunburn. It's just like a sunburn, really. You know, if some of the other side effects, prostate, you know, there's not really much of that. That's us men, you know, we kid about us, you know, the women always give us a hard time about everything we do. It seems to be easier. And it's even the case with radiation. I mean, literally, we lay on the table on a pillow with our hands on our chest in a mold between our legs and just sit there.
Yeah.
And so it's even easier. And there's really little to no side effects with that. With the prostate treatments, that's the biggest myth. Is it's painful. I'm losing my hair. That's the two myths that we hear the most often.
And I hear, you know, if I've had radiation therapy before, I can't have it again. Some people will come in and tell me that. And I think that was a little more true 30, 40 years ago, but nowadays the radiation therapy is so, again, precise. We can aim it. We can actually retreat a previous area that's had radiation therapy before. And we for sure, and this has always been true, can treat a different part of the body that's never had radiation therapy before. So that's a myth I hear sometimes. And then I will actually have not just myths that I'll encounter with patients, I'll have myths that I will encounter with other physicians who are not radiation oncology physicians. They'll come in, you know, and so, you know, patients getting radiation therapy and maybe they have diabetes and maybe their blood sugar's out of whack, you know, and the doctor will say, well, you know, you're getting radiation therapy, so that's making your blood sugar high. And I'll be like, well, not really, but okay. You know, we won't necessarily argue and call up the other physician and say that that's not the case. But there's a lot of, radiation therapy is kind of a black box, you know, it's mysterious. And you hear radiation therapy and it's got, you know, you're like the wizard behind the curtain, and it's really not mysterious at all. And it's very easy to understand. And if whatever comes up, if people, you know, if sit down, communicate with your physician, usually can clear up a lot of misconceptions.
All right. Thank you both for being here this morning. Radiation oncologist Dr. Todd Scarbrough and Chief Radiation Therapist Kevin Baker, our guest this morning on Cancer Corner. And if you have more questions, there's a website they can go to right quickly.
Yep, our alabamacancercare.com and our Facebook, social media. Look me up on social media. Look us up at our various centers across Alabama that Kevin mentioned, and we'd be glad to see you.
These guys are everywhere. We appreciate them being with us here on Cancer Corner this morning, a segment on Daybreak every Thursday morning.